if you have ovarian damage and a high FSH, or you are in a situation where you've got low estradiol, etc., we need to factor that in to our treatment conversation, because we need to be looking at, okay, what can we do in this moment for fertility if that's even an option? How are we working on egg quality? How are we measuring hormones consistently to see what's happening in the cycle? Can we get you into a fertility clinic for cycle monitoring and a mini protocol? Like, there's a lot of factors that we're making in the treatment room that can say, okay, how much can we do here?
Welcome to the Advanced Women's Health Podcast, where we empower women with the latest insights and advice on holistic health. From cutting-edge medical research to practical wellness tips, our mission is to help you thrive at every stage of life. Join us as we explore topics ranging from hormonal balance and reproductive health to nutrition and mental well-being. Whether you're seeking solutions for a specific health concern or simply want to enhance your overall wellness, you're in the right place. Let's embark on this journey to better health together. This is the Advanced Women's Health Podcast.
Hello, everyone, and welcome back to the Advanced Women's Health Podcast. Today, I am going to do a solo episode on a topic that we are seeing a lot, not only in practice, but also in the world of social media, online. We're seeing a lot of questions come up. And it's a really, really critical conversation around how women's health has changed in the last couple of years. And I want to be very clear that this is a sensitive topic. I want to be very clear that I'm not talking about this to induce fear. I am not talking about this to kick up any kind of emotion, which I know it will for some people, other than education. I'm here to educate. I'm here to empower. I'm here to give you information about your body. And the topic we're going to cover today and what we're going to talk about is the fact that in practice, we are seeing a lot more of something called premature ovarian insufficiency or challenges with FSH, so follicle stimulating hormone. And this is changing women's reproductive trajectories. It is changing a lot about cardiovascular risk. It's changing the fertility conversation. And again, it's something that we really need to talk about. So when we look at what FSH and POI are, right? So essentially FSH, follicle stimulating hormone, which I'll call FSH from now on, is the communication between your brain and your ovaries, follicle stimulating hormone. And so when we are measuring FSH, we're essentially looking to see how it's cycling with respect to one of our hormones called estradiol and how it's affecting different points of our cycle. So when we look on cycle day 3, so cycle day 1 is the first day of bleeding. On cycle day 3, your brain should be talking to your follicles, getting them stimulating, getting them going, but it shouldn't have to scream. I always say, just like a toddler, if your ovaries need to be screamed at in order to function, then we have an issue. And so FSH is generally, for the average person, somewhere between, I would say, 6 and 8, 5 and 7. Like for most people, those are the units we're talking about on cycle day 3. And with that, we have to measure estradiol, which is a sex hormone. And so estradiol comes from developing follicles. And we have this estradiol being released that will eventually trigger ovulation, right? So when we get enough of it, it's signaling you've got a ripe and ready egg, and boom, ovulation is triggered. And so estradiol, when it's high, tells our body, our brain, we do not want to make any more follicles. Like, we have enough, we're good. We don't ovulate 3 eggs. We want to just keep with 1, right? Our body likes a 1 to 2 cadence. And so it's very set up so that estradiol will come in and shut down FSH. So we need to be testing at least those 2 things together. Because if someone is, for example, perimenopausal, and they have a whole bunch of eggs developing in what we call offloading, then you can have really high estradiol. On day 3, it can be 700, 800, right? You can also have this with estrogen producing cysts, etc. But that's going to cause your FSH to look low, even if it normally was going to be a little bit higher. I promise this is the most complicated part of this conversation. Let's just get it out of the way, right? So When we are testing, it is a very important marker to test FSH. And this is something that you can test in the bloodstream. This is something you can also test in urine. We do both of those. And we are looking to see how is the brain communicating to the ovaries, and then are the ovaries responding in the way we expect? So in the case, again, of a healthy normal cycle, FSH, let's say between 5 and 8 on day 3. And then we see estradiol is, let's say, somewhere between like 80 and 180 type thing. So 80 and 150 if you're trying to remember easy round numbers. So if we're in a situation where that's what's happening, we had a normal follicle development, everyone's happy and healthy, then we think in that moment, we say, okay, this cycle looks good. Sometimes we do a secondary step where we test something called anti-Müllerian hormone, or AMH. And so anti-Müllerian hormone is a hormone that's telling us about how many of these follicles are little teeny tiny follicles that are kind of either waiting to develop or trying to develop. Again, I'm simplifying these concepts for my practitioners that are listening. Take what feels good, leave the rest. But I'm trying to create a visual understanding of what's happening at the level of the ovary. And so when we are seeing that AMH it's based on your age category. So essentially, how many eggs do you have in reserve is the concept or the theory. If you have a condition called polycystic ovarian syndrome, AMH is not accurate. It's going to be very high because you have a whole bunch of these little teeny tiny polycystic, tiny little cysts that are developing. If you have a woman who has a healthy egg reserve, then it will fit within the normals for her age category. And if you have someone sitting on the low end, they can be in two different situations. They can have a low reserve, right? And have a high FSH, meaning their brain is struggling to communicate with their ovaries, or they can have a low reserve and completely normal cycles. And so AMH, again, when we're talking about fertility, when we're talking about longevity, it can feel like a really overwhelming world. And so it's really important that we have these conversations and have these places to understand and be able to listen and re-listen, because I have these conversations in my office all the time. And so when we are in a situation where we have a low AMH, we'll start there, that doesn't tell you your chance of getting pregnant every month. That is going to tell you the longevity of your fertility. So it will say, okay, you know what, if you don't have a high AMH, but your FSH is normal and you're still cycling like frequently, meaning every kind of 26 to 32 days, your cycle hasn't changed, then we say, okay, you might want to try sooner rather than later. You might want to move up your timeline, but everything's looking good. When we're in a situation where FSH is high and AMH is low, that's telling us that there's ovarian dysfunction. So way back in the day, when I started practicing, fertility clinics used to say, when your FSH was over 10, meaning your brain on day 3, your brain was really starting to yell at your ovaries, they would no longer work with patients. They would say the chances of this successfully moving forward isn't great. Long gone are the days of that conversation, thank goodness. But essentially, we know that when your FSH is over 10, it's telling us that your ovarian function is declining and your brain is screaming at your ovaries. This could be a very normal thing, right? It could be mid 40s to early 50s and it's sitting right at 10 and you're in this camp where you're perimenopausal. But this can also happen and be between 10 and 20, right, when you're 20 years old. Now, that can progress to the point that we have an FSH over 20. That's where we're starting to look at premature ovarian insufficiency in most cases. We're going to break this down further. Technically, right now, that's where that diagnostic criteria would sit. Then we have a situation where it's over 40, over 80. As a general rule, when that's happening on a consistent basis, what we are looking at is someone who is at the very least perimenopausal, likely very close to that menopausal transition. And so that's what we need to know, okay? Those are the numbers we're talking about. We've got healthy, we have this dysfunctional range between 10 and 20, and then over 20 is diagnostic. So why is this an important conversation, and why is this a conversation I'm having right now? Well, we have seen over the last 5 years that there has been an exponential increase in women who are in that 10 to 40 camp in their 20s and 30s. And it's a conversation that is coming up a lot because we have people coming in for preconception work. They have normal cycles, they're regular, again, like the flow is normal, they might have some pain, they might have something like that going on, but they're not necessarily coming in because they have this huge glaring issue, because they have 22-day cycles or because they miss 3 months at a time for no given reason. They're coming in because they want to be as healthy as they possibly can going into this trying to conceive window. And we'll do some of these assessments. So we'll do on cycle day 3, we do FSH, we do something called LH or luteinizing hormone, which is involved in ovulation, and we do estradiol. Sometimes we do AMH, sometimes we don't. And we'll see results come up that are unexpected, that are indicating that there is some ovarian dysfunction. So the conversation from here on out, now that you have an explanation and you kind of know what's going on, is really about what are we doing as doctors and what are we thinking? Because it's a very overwhelming moment when that happens. Especially we have people in their early 20s that this is happening. Most of the time they're coming in with some kind of symptoms. Either their cycle has disappeared, they are experiencing really short cycles, their cycles have become very painful, very symptomatic, and they haven't been before. And again, we're seeing sometimes FSH in the hundreds. This is a very emotional conversation, which is why I put the trigger warning in the beginning. But it doesn't mean we shouldn't be educating on what's happening. So when someone has a high FSH, there are a few things going on. So when I first started practicing, again, way about 10 years ago, the only reason I saw a high FSH was in cases, and a low AMH in these situations, was in someone who either had a karyotyping issue, so genetic, or in patients with Hashimoto's thyroiditis. So we know that the antibodies, so meaning the immune attack on your thyroid, so autoimmune is when your immune system attacks itself, okay? So when we're looking at the Hashimoto's thyroiditis, this is a thyroid condition where your immune system attacks your thyroid tissue, it damages it, and to the point for many people that they lose function and they need to take supplemental hormones. 80 to 90% of people sit in this category with hypothyroidism. 80 to 90% of people with hypothyroidism, to be clear, not 80 to 90% of all of you, but they actually have an autoimmune reaction. A small percentage of those people, the antibodies from their thyroid can travel and also attack their ovaries. And that can create a state where the primordial follicles that should be developing, these like pre-eggs that are developing into these functional eggs that can be fertilized and therefore make a baby, they are attacked by the immune system and they are degraded and broken down. And so then we have a low AMH and the brain is screaming at the ovaries because there really isn't something there for them to develop. And so we're trying to get more estrogen from these developing eggs that just aren't there. And so we end up with this high FSH situation. So previously, that was the main cause. That was it. That was all, right? I think I probably saw 2 patients in the entirety of my practice history that we couldn't isolate a cause of their premature ovarian insufficiency. And so within that, it has changed dramatically. Now we know when someone has a high FSH, we're looking at, okay, is it a situation that they are actually, this is autoimmune. Now, whether that is autoimmune specifically from Hashimoto's or whether that's autoimmune from a different source, we look and we say, is there a source of autoimmunity here? That's situation 1. Is this what we call a situation? So again, is this a genetic situation? Is this Fragile X? Is this Turner syndrome, etc.? Very rare, but is it that? Then we look, is this what we call iatrogenic? Has this person had chemotherapy? Have they had a medication? Have they had radiation? Is there something going on here? Have you had ovarian surgery? Most people know that, but is it that? We look at, is this endometriosis? Because again, on your ovary, endometriosis can sit on your ovary. And when it sits on your ovary, it can damage those follicles as well and prevent them from developing. And then we look at, is this viral, right? So we know that post-COVID, we've seen a dramatic increase in the cases of premature ovarian insufficiency and a high FSH. And so within that, we have seen that the virus can actually enter into the ovaries and the testicles. We actually have seen what's called azoospermia, so like no sperm in semen analysis as well. But you can have the virus enter the testes and the ovaries and create so much damage that one of a couple things happens. And this is where it's really, 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 really critical that you don't see a high FSH for your age category and assume that it's just premature ovarian insufficiency. There's a lot of things going on here. So this is where we're going to get a little bit technical. Again, this episode might not be for some people, but if you know anyone who has a high FSH, it's for them. So send this over to them because there's a lot we need to be thinking about here. And as clinicians, I have a lot of clinicians who listen to this podcast because I train naturopathic doctors as well and nurse practitioners. But within that, we need to think differently about this. So when you have a high FSH, that does not mean that you are in menopause. It might not even mean you're in perimenopause. So we have situations right now where we have patients that have had so much inflammation around their ovaries that their ovary function is not actually damaged. It's shut down, right? In technical terms, we call this the cell danger response, right? Or this protective response, where the ovary just stops responding. So when you look at an ovary on ultrasound, right, you can have a big ovary, which might have a cyst on it, okay? You can have a normal size ovary, which is about 5 to 12 cc's for anyone who cares, or you can have a teeny tiny little ovary, meaning it's not functioning very well. And so we can see these situations where there are these ovaries that have enough follicles in them, but the FSH cannot actually communicate properly. And so it's not that these people are in a situation where they are technically in perimenopause or menopause from a low egg reserve perspective. It's that there's so much freaking inflammation that the ovaries are not responding. So in these situations, if you want to move forward to try to conceive, it's a very important conversation that you're working with a fertility clinic and a naturopathic doctor, because honestly, this is the world of naturopathic medicine. This is what we can do. But you need a fertility doc that understands what's called the immune protocol. And you need a naturopathic doctor who understands virology and who understands what's actually happening, because it's very clear in the research that there's ovarian suppression, okay, which is this state where the ovary is suppressed. It's shut down. It's scared of all the inflammation. There's ovarian damage, which is autoimmune or virus or something has damaged those developing follicles and they cannot develop anymore, right? This person is going into menopause. And then we have this situation where you are essentially, the ovary wants to function as fine, but there's an issue with FSH receptor. So in any situation, the immune system is at the core and at the base of this and needs to be understood. But if you are someone who has a normal, what we call antral follicle count, or they can count in the process of a fertility clinic or in the process of development, right, or they're doing an ultrasound, they can count that there is a normal-ish amount of follicles developing, then you're in a situation where your fertility may still be intact. And so we operate and we treat these things very differently than someone who does not, who has an antral follicle count of 1 or 2, right? Meaning there's not that many eggs developing versus, again, in that range of 6 to 8 per ovary. So when we're looking, if you have ovarian damage and a high FSH, or you are in a situation where you've got low estradiol, et cetera, we need to factor that in to our treatment conversation, because we need to be looking at, okay, what can we do in this moment for fertility if that's even an option? How are we working on egg quality? How are we measuring hormones consistently to see what's happening in the cycle? Can we get you into a fertility clinic for cycle monitoring and a mini protocol? There's a lot of factors that we're making in the treatment room that can say, okay, how much can we do here? Then in that situation, we're looking at hormone replacement therapy and what we need to do to ensure that someone's cardiovascular system, so their heart health, their brain health, their metabolic system, and their bones are protected. If you are 20 years old and you are essentially going through menopause, even if there's some degree of regular cycling, but your hormones are very, very low when we're testing them consistently throughout the month, we need to understand that there are huge implications later in life to these things that are being ignored. So we need to understand this. Okay. The second situation is when you have so much inflammation around your ovaries that your system is not responding properly. In that case, we are working on the immune system in a very aggressive way with the conventional medical model, pharmaceuticals, and also using herbal formulas, dietary change, acupuncture, etc. So we have seen clinically, and I would say this is a lot more clinical data at this point than it is some stuff that we're seeing in the research. Just because for the most part, when you go to your medical doctor, if you have a high FSH, that's it. That's done. The conversation is over. Some of the more progressive fertility clinics are taking it further, and we're getting some of their early data. But this is really only the last 5 years that we've seen such a huge uptick in this. And so that is nothing in the world of research. That is no amount of time. So clinically, because again, we're advanced women's health, we see a lot of this. We are seeing that you can make big impacts in this population, and you can have people ovulate, and we do have people conceiving. And so it is very much something that you can focus on treating, but again, needs to be treated aggressively. The subcategory of that is the FSH receptor resistance. It is really hard to know if that's what's going on or if the whole ovary has shut down. There are some very technical things we can look at that we don't need to get into today. But for my practitioners listening, it is important that you understand the difference between those things, because that's where our difference in hormone replacement therapy and prescribing comes in those cases. But in any situation, what you need to know is if you have high FSH, you need to then understand how your hormones are cycling throughout the month. Are you ovulating or are you not? What do you need to do, right? From a anti-inflammatory perspective, is that with herbs and acupuncture and our world, right? Nutraceuticals, is that pharmaceutical? Do you have a doctor who understands the pharmaceutical protocols that work? If not, get help. We've talked about this on the podcast. I do a ton of endometriosis, and you can see cycling high FSH or consistently elevating FSH in endometriosis. And so given that I have so much experience in that world, there are specific immune protocols that I will get patients to embark on, especially when they've been through 1, 3, 5 IVF cycles. I'm like, okay, we need to do the immune protocol and then we can move forward. So within that, we see really significant changes in FSH. We can see FSH drop and drop permanently, which we're told shouldn't happen. And I think I always like to realize and recognize that the impossible is very possible in the hands of the right person. And so we'll see FSH drop from early 20s down. I've even seen it go from 40s down to 6. So these things are very possible, but you need to be working with the right team who understands the intricacies. This podcast today is really just to educate and inform a very small, a growing but small subcategory of women who have a high FSH and they're told that's it, that's all, they're done. They're not given the follow-up. Because if your ovaries were attacked that hard, guess what? So were other organs. And so we need to understand that and not only replace hormones and educate about hormone replacement and bone health and heart health and metabolic health and brain health and all of these things, but we also need to look at the inflammatory impact on other tissues and treat you holistically. So those are really the things we have to think through. And these are the investigations that we need to do to understand what your actual fertility status is, because we can't just look at FSH anymore and say, okay, that's it, that's all. We can't even just look at AMH anymore and say, okay, this is your reality. This is now what's going to happen. The world of fertility has changed in a dramatic way, and we need to start to share more information about this.
Today's episode is brought to you by none other than Advanced Women's Health. If you are interested in diving in deeper to your health, if you are finally ready to feel like yourself, and you are finally over hearing everything's normal, everything's fine, and you want a deeper dive into your healthcare, then we are here to help you. We are currently helping patients in British Columbia and Ontario, Canada, But don't worry, if you're in another province, still reach out, get added to the waitlist as we expand coast to coast. We cannot wait to work with you. Check out the show notes for more information on how to get started.
So, a couple things that I think are really important that we go through. Again, and this is reinforcing what I've already said, but these are myths when I put out in the past about questions on this. These are things that have come up. So one, a high FSH means you're infertile forever. Again, not necessarily the case. When your FSH is over 20, 25, that's when we're sitting in the camp, especially when it's combined with a low estradiol, right? And a low AMH, that's when we're sitting in the camp of saying, okay, you may be in a category of premature ovarian insufficiency, but we need to understand, is that FSH receptor resistance? Is this ovarian suppression? Or is this actually damage and you do have POI that needs to be treated? We also have the category of people between 10 and 20, where there's a lot of interventions that we can do. There's a lot of antiviral work, again, pharmaceutically and from an herbal perspective. There's a lot of egg quality work we can do, a lot of anti-inflammatory work that we're doing in that category to help establish and support someone's ovarian health. We also look at whole pelvic health. We look at the vaginal microbiome. So a lot of the things we talked about in the endometriosis podcast apply here as well. Another myth that we hear a lot is that premature ovarian insufficiency means you're in menopause. It means you're on the road, right? You have headed in that direction. I have patients that went from regularly cycling to getting a virus to stopping cycling the next day. And when 6 months went by and we're like, this is very strange, doing hormones and seeing estradiol low, progesterone's non-existent, we see elevated levels of FSH, elevated levels of LH, like that person's in menopause. I've seen it happen that quickly. But we have that category of people who are, their FSH is 20 to 25. It does not necessarily mean that they are going to go into menopause tomorrow, but it does mean that they need to be monitored and supported. And we need to educate on how to ensure appropriate hormone levels are in the system for long-term health. Another myth, again, is that there's nothing you can do. As soon as your FSH comes back high, no one will help you. Very much not the case. There's so much we can do. And I think I've broken that down quite a few times today, but we're looking at the immune system. Is this autoimmune? Is this currently active damage or is this past damage? What's going on with the quality of the eggs, which plays into the mitochondria? What's going on with the vaginal microbiome? What's going on with the uterine lining? These are all things that we are looking at and tackling and understanding in addition to the basics: nutrient deficiency, blood sugar dysregulation, the gut microbiome. These are all the fundamental pieces. And then we're doing a lot of work on sleep and nervous system in this category, because as your hormones shift, your sleep can shift and your nervous system can shift. And this is a highly emotional time for a lot of people, even if they didn't want to conceive. They're like, what does this mean about my femininity and my hormonal health? And so there's a lot that goes into it, which is why, again, you need to have really strong supportive relationships with professionals who are dealing with this all the time. We see thousands of patients a month at Advanced Women's Health, right? And so within that, we get the opportunity and get exposure to a lot of these cases. And so we can help navigate in a different way than a lot of practitioners that are in solo practice. It's just facts. And then another myth is that there's something you could have done to prevent this. I have not seen that to be true. Most of the world has gotten COVID, right? And other viruses. And we're not in a situation where most of the world, thank goodness, at this point, has some kind of ovarian dysfunction. And so it's really important that you take that on and understand you did not cause this. There is likely nothing that you could have done differently. Now we know differently, right? So what we'll see is that for some women who have this ovarian suppression, we can bring their FSH, their LH, their estradiol back to a normal limit. But then if they get another virus, we can see those things fly up like crazy. And so now we know in those situations, there's lots we can do, right? There's lots of antivirals we can put in place. There's things we can do to support the viral immune response so that it doesn't go back and damage the ovary yet again. But there's nothing you could have done in hindsight because we didn't know this was happening. I didn't know this was happening. The research didn't know this was happening. And so I really want you to take that on, that this is not something you can blame yourself for. This is not something you could have known better. This is not a lifestyle factor. Even those with Hashimoto's that have a high FSH or premature ovarian insufficiency, a small subset of women with Hashimoto's have this. And so all we can focus on is what we can do moving forward. And there is a lot of factors that need to be taken into consideration with an appropriately educated practitioner. So I hope that that helps. I hope that you are feeling empowered, or at least a little bit more educated on what's going on in your body. I hope you share this with someone who is going through a confusing or tough time in their fertility journey, because these are things that I want my patients to know. And I actually honestly am recording this so that I can send it to patients who are struggling to understand what's happened in their bodies. And so listen to this. You might need to listen to it 2, 3, 4 times. I tell my docs this all the time. You're not going to get it on the first listen. Our society is like, we read a book and we're done. We listen to a podcast and it's over. The learning happens, the integration happens sometimes on the 3rd or 4th listen. And especially because this is a hotly emotional topic, it is very, very, very common that your brain just disassociates or shuts down multiple times throughout the conversation because it's too painful to take in. And so I want you to honor that and go through and re-listen and ask questions, post comments on our Facebook, send a DM to either the Advanced Women's Health Clinics or my Dr. Sarah ND Instagram. We're here to support you. There's so much we can do, and we really want you to have a different and more empowering experience in your body. So if you like this episode, this podcast where we go really deep on a subject, I know it can be overwhelming, but if you like it, let me know. I am so excited to be able to share this information because I am very much not excited to have to tell patients this information in my office, but I do know that we are coming into a window of time where it's been 5 years since the pandemic. There are going to be people who did not plan to test any of their hormones until they were 35, 40 years old that will listen to this and test earlier. And then there will be something we can do, because we don't know if it's 10 years post-virus, if we can help the same way we can 5 years post. So again, not to scare you. This is to empower you. There's so much we can do. There's so much support we can give. And I really hope that you feel empowered by this information. So that is it for me today. Have a beautiful day, and I will talk to you very soon.
Thank you so much for listening. I hope that you had as much fun as we did. And if you loved today's episode, share it with a friend and leave us a review. That is how we spread this message, and that is how we are going to revolutionize healthcare in Canada for women. Have a beautiful day and be well.